Informatics short course. I'm so thankful that you joined us for today's session. And to those who don't know me, I want to take the chance and introduce myself. My name is Razan Ematullahi. I'm studying for Masters of Geriatric Nursing at Tehran University of Medical Sciences. And more importantly, I'll be hosting today's meeting. So, since it is an international course and we have lots of participants from all around the world with different time zones, of course, I would like to say good morning, good evening, and good night to you all. This series of our short course is in Technology Solutions for Telenursing and Generating Knowledge. It will take you to get it completed. You will have a month of synchronous lectures consisting of 4 lecture sessions and approximately a month of asynchronous program. And today is the second session that we're holding. Just gonna add that today's session will end at 7:45 p.m. in Tehran time. And also I gotta tell you that recorded sessions and slides will be available at the program website in case you need to reread or review them. One more last thing before we getting started. I sincerely want to appreciate Professor Tony Hebda, Dr. Melody Rose, and Professor Carolyn Sipes, the distinguished experts in the field of nurse informatics from USA, for making the time to present their fantastic lectures. I also want to thank to Dr. Khater Seizani, Associate Professor of Critical Care and Nursing Management Department, and the Program Director, Dr. Asya Darvish, Lecturer of Medical Critical Nursing Department, and the Program Moderator. And of course, all colleagues who've done a lot for making this meeting happen. And so first, dear participants, please answer the poll questions, which will be launched on your screens. And after you finish with the poll, we're gonna have Professor Sipes start presenting her lecture. Is the poll launched or not?
Yes, it is launched.
All right.
I can see on the screen.
Yeah, if you could share the screen, that would be awesome.
Maybe you just should click on polls because we can see. No, it's 7% participated.
All right, we can wait.
This is now 37%.
Well, nice progress.
40%, yes.
Interesting responses.
Thank you. Dear audience, please participate in the poll, then we can start and enjoy the lecture of the Professor Sipes.
This is good.
Everyone, please do the poll. It's just a little matter of time.
Yes, it's 53%.
53, good, good.
%58%. We wait some more.
Yes, I'd be interested in seeing more for especially some of the other questions.
Yes. And this is 57%. I think we can wait for 60%, then we can close. This is 59, 61, okay. 62, okay. 63%. And I think it's okay. We can close the poll. Do you agree? 64%. Okay, thank you. Now it is closed. You can continue.
All right. Everyone, thank you so much for your participation, and I will continue. Now, please welcome Professor Carolyn Sipes. As a professor, she has more than 35 years of clinical research, academic, and informatics experience. She's a certified as an advanced nurse executive, NEA-BC, and informatics nursing specialist, RNBC, by the American Nurses Credentialing Center, ANCC. Published a project management for advanced practice nurses, application of nursing informatics, competencies, skills, decision-making, texts, as well as numerous other peer-reviewed publications, books, and book chapters, and presented both nationally and internationally. Professor Sipes, please take it from here. You're all listening.
Okay, slide.
Professor Sipes, do you have my voice?
Yes, I do. I'm sharing, but it's not.
Yes, we can see your slides.
Oh, you can see it?
Yes.
Okay,
Yeah, we
good.
have it clear.
Okay.
But we don't have the presenter view, Carolyn.
I may not be able to do it with this. I know I have some restrictions sometimes, so let me see if I can.
Don't worry about time. It's very nice. We have your lecture, so please take it easy.
Okay, let me see if I can. So you can see this, but I know that you want it.
Yes, we can
What
see.
is the problem you're facing? What is the problem?
I don't know. Dr. Head just said you couldn't see the presenter view. So can you see it?
Now we can
We
see
can-
it. We all can see it. Yeah, yeah.
Okay, all right. Okay, I want to welcome everybody. This is Dr. Carolyn Sipes. I was introduced and presenting telehealth and telehealth nursing today. The agenda is giving you the different definitions, distinguishing between the different types of telehealth and telenursing, distinguishing and discussing the application to practice. I'm going to review some of the research that's been done for curriculum development, looking at the things, tasks, skills that are needed that we teach in programs, skills, and the competencies, certainly. We're going to be discussing advantages and disadvantages to telehealth nursing practice, identify issues related to telehealth nursing practice, such as security, interoperability, legal and regulatory issues. And the information I'm going to be sharing there is regarding the United States. So, and the last one was, again, there's a self-assessment quiz. So with this, and I can't see, with this is the what telehealth is. And again, this needs to be a different screen view because I cannot see the full slide. So is there an advance on this? Because I'm not advancing these.
We can see.
All right, I'm not advancing. Let's see there. There's the overview, the self-assessment quiz. And this needs to be, I'm sorry, this needs to be a different view because I cannot see the full slide. So how did it get to be so the full slide?
Do you agree we share your slides?
Full size. I have it all.
I do not want full size because I cannot see the full slide. However, it was set, and I didn't set that, so I don't know what that is. All right, we have to go back. What?
Zoom back. Now we.
I know there's too much, so
Yeah.
we need to go back to, and I don't have the controls at the top.
You want to close it and reopen it.
Yes,
What about
I
that?
do. Yes. And I don't want to leave. Stop video. I do not have the controls for some reason. Does somebody else have the controls that you're running this?
No. Can't you just close it? Can you just close it and then open it?
Just if you agree, we can share your slides.
All right,
And
that would be
control
good.
it.
Yeah,
Yeah,
would
we
have-
also can do it. Of course.
I would have to leave.
I think if you can share her slides, then she will have the presenter view locally and it will be perfect.
That's,
Okay,
Yeah,
now
thank you, Darvish.
your slide is here. Is it okay?
this is better. This is perfect. Okay, don't anybody move.
So please
Because I
just
don't have those controls.
let me
Okay.
know whenever you want to go to next slide, okay?
Okay, all right, this is
Thank
good. Okay,
Thank you.
and providing the telehealth overview, these are the different definitions. Sometimes telehealth is called telemedicine here. And again, the information I'm sharing with you is the way it typically is here in the United States. It may be different in different countries, different terminology used, which may cover all of telehealth, telenursing, telepharmacy, that type of thing. So sometimes, again, it's called telemedicine. And this is where the provider provides care without face-to-face office visits from a distance, and is done primarily electronically, online with internet, access to the computer, tablet, or smartphone. And this definition comes from our Center for Medical, CMS. So further definition of telemedicine, again, includes mobile health, mobile M-health, telehealth, e-health, and you'll see here in the United States that telehealth is typically, and tele as the prefix for pharmacy, all kinds of different definitions. And you'll see at the bottom of the slide, I have it marked with a red asterisk. This was one of the questions that was on the pretest. So just letting you know, I have identified these. So I saw the responses on the pretest, and the majority of them were marked with face-to-face office visit. It's telehealth is without face-to-face office visit. Okay, next slide. The difference in telehealth versus telenursing, the definitions, at least that apply here in the United States. Nurses apply telehealth technology as a tool to provide care in a variety of different ways. And we've tied this recently with presentations last year, tying it to our nursing informatics, because there is a lot of overlap between the skills needed for the nursing informatics and for telenursing. They're essentially the same. You need to have the background in technology. So our tool it provides care in a variety of ways. And I think you've all heard of, back to the previous slide, you've heard of the social determinants of health, where we need access for vulnerable patient groups, older populations, and it gives them greater access for those who live virtually and rurally. We have a lot of rural areas here, especially in the West, in the United States, where patients do not have access. Recent access and current access. And we also have states that are widely spread further west, for example, Wyoming. Sometimes students or patients have to go travel 500 miles for access for healthcare. And Montana, they're very widely spread with very few access to healthcare. So this technology provides the telenursing, provides access to care for assessments and different kinds of things. So it also provides access for those living with multiple chronic conditions, and then having to travel is a burden. For example, diabetes, or someone who has some limitation with access to mobility devices, traveling, wheelchairs, that type of thing. So using the technology really is a tremendous advantage to access to care. Another thing that it addresses, the tool can address, is patient education, and certainly remote patient monitoring. And as you can see, this is an education program, and we're doing it virtually, which is a tremendous advantage, especially for, I teach at Walden University, an international university, and we're a totally online university where we have students from Africa and essentially all over the world. that can attend our courses and, get their different degrees, master's, PhD, that type of thing. So next slide. Additional things that apply to telenursing is using technology as a tool. Certainly is the patient education, as I mentioned, primary care, health promotion, assessment, diagnosis, treatment of acute and chronic diseases, and care provision, especially with when patients are quarantined, as they have been within the COVID pandemic. And again, I mentioned treatment and assessment and diagnosis, and that applies to our very remote areas in the United States, especially the Northwest, where again, it might be 500 miles to the nearest healthcare facility. Another one that technology provides for is a telepresenter. And this is something new that was initially brought forward during the pandemic. And this is someone who's there who provides support to assist the providers in remote areas. Telehealth nursing for school health, school-based healthcare. Again, this is where that schools might be closed down, and the students, younger students who are being monitored by nursing for different things such as diabetes and that type of thing. The nurse can check in virtually with the students, the children, to make sure that they're getting the medication, they're being monitored for diabetes, that type of thing. Telenursing can prevent direct exposure, certainly during the pandemics, and this is probably what you are thinking about most. The biggest advantage to telenursing is the direct exposure, where you don't have to go in to a physician's office to be able to get the care. And it could also apply to flu epidemics, which we had previously, but had not used telenursing to the extent we're using it now with the pandemic. And as you notice, there's another red asterisk here. This was another pretest question. So the answer to this is telenursing provides access in a variety of different ways, and it was all of the above. So next question is, next slide is the three main types of telenursing delivery models. And I found this interesting because it's not universally known. So this was, the three main types are store and forward technologies, and this enables transfer of diagnostic and imaging information. The live video conferencing, and I think this might be the one that you're most familiar with, certainly is using telecommunication technology for patient assessments and that type of thing. And then remote monitoring. And this provides when monitors patients remotely using technology. And again, this goes back to and reminds me of when I used to do high-tech home health care, where I would go out and administer IVs to patients for a variety of different things like antibiotics, or go out and do a home care visit to monitor a patient with diabetes or something like that. So, and that reminds me that remote monitoring is essentially not new. Some of these other modalities are newer. So next slide is defining these more in depth. Store and forward technologies certainly enables the transfer again of diagnostic imaging, as I mentioned, and physiologic data, such as the data digitally generated, then it's stored and transferred when it's needed, and the patient doesn't have to be present. And this is really valuable for different organizations, hospitals that are sharing the data and the vital signs and other data, diagnostic imaging back and forth. And this example I know because of some issues that came up in Cleveland Clinic, where one of their clinics had needed the information from a patient, and they were going to repeat tests that had already been done, such as EKGs and other x-rays. And the physicians talked to each other and said, no, we already did this. Can you just send them? So this is an example of this technology being used to, again, prevent extra tests and that type of thing, such as MRIs, CTs. Certainly vital signs is an easy one to transfer back and forth, and the lab values. So next slide is the live video conferencing. And this is using the telecommunication, the technology for two-way communication using the computers, microphones, software. And I think you're probably, again, most aware of the video conferencing capabilities of using telenursing in this way. Live video conferencing can be used for live visits, again, such as urgent care, patient education, that type of thing. The other thing that this can be used for are the virtual office visits, and again, as well as the remote monitoring. And this is an example, and I can use it personally, as I had an issue earlier this year where I needed to go in for an evaluation, and said I couldn't because we live on up on a mountain, and it was snowing, and it snowed 16 inches, and it was impossible to be driving somewhere. And I said, I need a televisit. And so we were able to do the televisit, for an update and assessment. And I had broken my leg and needed some, the surgeon was monitoring feedback for different things. And so I requested the televisit, which worked. And especially, we're in the West, and we have these kinds of things coming up all the time with snow and blizzards and, inability to travel. So that was very beneficial I was very glad I was able to have that televisit. Next slide is the remote monitoring. And this is when the providers monitor the patients remotely, again, as I mentioned. And for me, the best example was when I did the high-tech home visits for in healthcare. And this was a while ago, so it's not essentially new. And this is using mobile devices, tablets, that type of thing. That's probably the newest part of this, is when our patients have to have the correct devices that can access, the broadband and the internet, and certainly transmitting daily vital signs, lab values, that type of thing for diabetes and heart disease when that's being monitored to get a patient back into compliance. So the next slide, we're looking at barriers to telenursing practice. And again, you can see there's the red asterisk. This was one of the questions. What are some of the current barriers? Telehealth was originally most recently defined as a disruptive technology. And I think you can all relate to that because it changed access to healthcare, and it was very immediate and rapid with COVID. And it was March 16th, essentially, here, where all at once everything closed down. if you look at the data, you'll see an immediate spike in the telehealth access and use. It was immediate because all at once, everything shut down here in the US, and it's now you can no longer have face-to-face visits with your physician, your provider, and it needs to be virtual. So that mandate was essentially overnight, and then hospital groups, healthcare groups scrambled to get something in place very quickly within 3 to 5 days so that patients, they could access patients. There could be the two-way communication. But some of the current barriers, and in a previous telenursing presentation, I presented the barriers, and it was essentially pre-COVID. These are current barriers that still exist during COVID and more into post-COVID. So the technology and infrastructure is still limited, and especially not in the suburban areas and the major areas, the larger cities, but still within some of our rural areas. I'd mentioned, you know, Wyoming, Montana, where patients still have to travel maybe 500 miles for access. The other thing is if they don't have internet, and this is something that we're working on, the government is working on as a goal to have high-speed internet as available to everyone. I mean, our Congress is working to pass laws that should be mandated. You know, it should be more of a priority now. Cost is still, some of the excuses they're using is prohibitive, certainly in the remote areas where they don't have internet access yet. Licensure, this used to be a big issue, not so much anymore. And again, our federal government is really working to address these issues. So legal restrictions on practice, especially across state lines, where a provider has to be licensed in each state. Nursing has worked to make sure that it's cross-state, receptive across state, and accepting that nurses can practice in other states without having to have an actual license there. So they're working also for physician practice to be the same way. Then also another barrier is living with multiple conditions, as I mentioned earlier. And it includes those who have less access to online resources, and certainly cultural and linguistically diverse backgrounds. And again, this might be, language in our Hispanic and populations like that, where we also have migrant workers, may not have the access online that would be needed to be able to cover their healthcare practice. So an additional barriers include looking at reimbursement issues, since and this is on the next slide, reimbursement issues, lower lack of telehealth in, again, the remote areas that I mentioned. Some of the areas are not getting the funding. We have, like, our American Indian population, where there are still issues with getting refund or support from the government in getting support there for access. Certainly resistance, there's a lack of, in some areas, there's a lack of buy-in and resistance. There's a big issue that's been consistent in anything that happens within healthcare, certainly, is the resistance to change. You know, there's many times there's the attitude, if it's not broke, why do we need to fix it? And it's, the lack of acceptance of, oh, here's something new that can really help and move you forward. So again, it's looking at behaviors and attitudes that really need to essentially convince whoever it might be that this really is a benefit to practice. And there's issues such as lack of trust in the technology. You know, if there's something, an organization is not working well, where the technology is not working well, then providers might get up and just essentially walk away and say, you know, fix it, and then I'll figure out how to work with it. Many times we've had to have champions, you know, for example, other physicians that are using it well come in and really do shoulder-to-shoulder education to somebody who's having issues, a provider that's having issues logging in. I've seen it so many times in working in getting our EHRs up, electronic health records up within different organizations, where someone will come in and they're not computer literate, essentially, and just say, I'm not doing this. And the physicians have hired scribes to enter the data for them so that they don't have to do it. They've come up with a number of workarounds. So there's still issues around resistance. And then as far as patients are concerned, there is a lack of acceptance and competencies. And I'll get more into this a little bit later, talking about the competencies, patient acceptance. You know, typically older populations are not computer literate. They're not used to having used a computer for anything. And so now they're having to learn. Other barriers are provider skill sets. And again, this goes into the resistance. The competencies are lacking. And I've seen that a number of times where a physician will just say, I'm not using this. And when we were trying to implement our EHRs in several of the different major healthcare organizations, physicians would get together and call in, you know, the day of the go live, would call in and say they had the flu. So it was a blue flu, essentially walkout in protest for the new EHR. Others, it was sad to see where nurses would quit because they didn't want to take, you know, they were embarrassed essentially because they didn't have the skills and they weren't willing to learn these new skills. So that was really sad to see. There is the issue of human computer interface and usability. And again, this all goes to competencies, skill sets, the telehealth literacy. You know, this ties into a number of issues. And then certainly older people, patients living rurally have less formal education, and it may be the lower socioeconomic status. And this would go to our different vast areas in the West where there are migrant workers who do not have access or, you know, cultural, linguistic competencies. So with that, we're going to move into issues related to telenursing practice. And this was an interesting study that I found, and it goes to work that we have also been doing in the US. Dr. Hebda and a research group at Chamberlain University worked on the nursing informatics competency assessment, a NICA tool looking at competencies, and that was for nursing informatics, which is essentially a framework for telenursing practice. So this study outlined a number of issues related to the practice in looking at curriculum development, and there was a lack of the knowledge, skills, and attitudes, the KSA. And this study was from the Netherlands, a very extensive study that looked at what the competencies should be, the basic competencies required in order to practice telenursing in a competent way. And this was a study from 2016, And I will certainly willing to share this information. It's also in the reference list at the end. And I think it's a really important practice, but what they found there are essentially very similar to what we've done within the nursing informatics group. It's a very, it's tied together that you need these skills. So what they identified in this research study were what they call the professional nursing telehealth entrustable professional activities. And what they've identified and labeled these as is there is for the team that's providing care for the patients, that they do need the minimum of these 14 specific core competencies, the major ones, and then within those major ones, they need at least 10 of the skills within the major ones. So it's like the major core competencies, they identified 14. Within those, they need at least 10 sub-competencies, if you will. And they came up with a total of 52 competencies that were identified that are essential for telehealth nursing. So with this is developing the telehealth nursing programs. It's based on research. Again, this study was in the Netherlands in 2016, but it very much ties to a lot of the other work we've been doing here in the United States, looking at and trying to define the different competencies that are required for nursing practice in general. We have the ANCC, American Nursing Credentialing Center, that has identified the essentials and has listed those. There are other different organizations working on identifying and trying to come together with a standard list of competencies that are really required for practice. And everybody has essentially, they're kind of going off in their own way, but I think there's a tremendous amount of overlap in what everybody else is defining. So within this, this research study, all nursing telehealth activities, except this one I'll show you, or these two that are related more to psych, needing the psych background in order to practice. And they require knowledge sources ranging from 2 to 4 different types. So within this, the basic that they found needed as a priority are clinical and procedural knowledge. What do you do in case of emergency when you're providing care for telenursing care for an patient? What do you do in case of an emergency was the most frequently selected knowledge item. And then within these basic essential practices requires, again, the specific set, which is at least 10. And again, they came up with 52 competencies that were identified as required for competent telenursing practice. So within these, in the next is looking at the major categories. And this is in the next slide. The major categories that they identified as core. And again, within these major categories are the others that essentially the sub-competencies. So within the major categories, coaching and communication, and I think you can all relate to this, ability to combine clinical knowledge and experience in telehealth. You need to have some experience in doing this in order to be able to provide competent care. You need ethical awareness, a supportive attitude, general skills such as analytical and implementation skills. For example, in telenursing, you have data coming across, for example, patient's vital signs. So you need to know where you chart this type of information so that it can be there for everybody to see, all providers' ability to see it and access it. So a major question within that is, what knowledge, attitudes, and skills do nurses need to acquire before they can be entrusted with telehealth activities? This was the major question they asked in this research that they conducted. And I think it's a key question for anybody practicing telenursing. And are you competent to be able to care for a patient? You know, if with these skills, do you have the skills? So within those, this next slide shows the 14 major areas required. And this again was another question on the pretest. Can you, for example, and I'm not going to read all of these, but you'll have this list. Can you support patients in the use of technology? Number 2, can you train the patients, again, in technology? And this goes to computer literacy. If you're trying to get a patient to send you their daily report on their vital signs, can they do it? Are they competent? Can you help them? Can you provide health promotion remotely? And that's, for example, diabetes. You know, can you educate them? Do you have the information you can send, you know, to maybe their iPad or something like that? Can you triage the incoming calls and alarms? And this goes to your competency and ability to access and use the computer and the technology in a competent way to get this information to providers as quickly as possible and not, you know, be missing important data. And can you analyze and interpret incoming data? So again, you know, this goes to the telenursing competencies in order to be able to accept patient care within this realm of telenursing. And I'm not going to read all of these certainly, but you know, you can go through these, you know, independent double check of high risk medications. Can you coordinate care with the use of telehealth technology within your team? Are you able to communicate and send the data that's necessary to adequately, you know, for PT or lab values, or, you know, and then send med orders back to a patient, especially, for example, if they're using an iPad or something like that. So the next slide, and again, back to this is a big research study. And again, I will share that information. It's a very interesting article in how they went through, collected the data, and where all they accessed data and came up with these 52 practices, knowledge, KSAs, skills, and attitudes needed to be competent to practice telenursing. And to that, it goes to developing a competent program within our master's and PhD programs to educate nurses so that they are competent. And it even goes to, we started some of this, for example, the nursing informatics in the master's program at Chamberlain, and then it's moved down to the bachelor's program. So nurses are becoming more and more competent. The requirements within faculty and universities is that these programs, curriculum programs, need to be available to really help in educating nurses earlier and earlier in this technology. So now to advantages of telenursing. And again, this was a question in the pretest. So what has the pandemic done to impact telenursing and patient outcomes? And again, you know, if you summarize a lot of what I've already mentioned, it comes to nurses' perceptions of improved quality of care, the face-to-face provider to patient. And essentially that's why it's really important for telenursing and the face-to-face, if you will, virtual versus a telephone call. Think of, you know, calling a patient and you're not seeing them or their nonverbal behaviors, that type of thing, and they can't see you. So again, you know, it's a the Zoom and the face-to-face virtual visits have been really critical. Social distancing, certainly with infection control for our pandemic, increasing mobile workflow, certainly with iPads and other mobile devices, reducing travel time, I've mentioned several times, and access to care. It's certainly decreasing wait times because you have a televisit, a telenursing visit, you have a certain time, like 10 minutes before, and then they come on, you're there, or even 5 minutes before, you log in, and then they jump in. So that's a tremendous advantage. And improves patient compliance. They've done research and found that it certainly improves patient compliance. So with the next slide is looking at some disadvantages though, and these are things that we really are working to resolve within our practices here in the United States, looking at putting in different programs we have, and I'll get into this in the legal and regulatory a minute, with putting in some federal compliance areas to meet some of these issues. So within disadvantages certainly is the difficulty with technology. You know, are you computer literate? There's not only, you know, your computer literacy, it's looking at equipment inconsistency, malfunction, you know, that really goes to trust, that trust issue I mentioned earlier. If it doesn't work, you know, you're really not going to trust that you're going to be able to be competent and really help these patients. Lack of computer literacy skills and competencies, again, and that goes to that research study that I just mentioned. Other questionable therapeutic relationships using virtual visits. And the one that came up with this was, is it really, you know, looking at the psych mental health assessments and visits, looking at those, are they really therapeutic? And some of the research that's come up is looking at empathy. And they're saying empathy is missing. I actually have some PhD students looking at the using digital technology and getting feedback. These are qualitative studies looking at experiences of patients using digital technology. And some of the things that have come up is empathy is missing. They don't feel that talking to somebody virtually via computer is, the empathy is missing. And so we're really focusing on asking the patients questions. What do you feel? You know, some of the feedback that came back in the research study was, well, the nurse is just sitting there typing on the computer with her back to me all of the time, and she's not looking at me. She's not, you know, the face-to-face interaction, the behaviors, the smiles, the nodding assessment. Yes, I really understand what you're saying. And so found within this research study, this student is completing now, is asking them, what do you think implies empathy? And trying to get that information back. So this was an interesting research study. There's some others out there as well, but her study, I think, is really interesting, something we hadn't really thought about before. There's a lack of end user adoption with lack of integration with the new technology in clinical practice. And I'll get into this some more a little later, looking at this, the interoperability, where the different organizations, and you see it here in these big areas where there are, you know, multiple large healthcare organizations, everybody wants to do their own. You know, it's like, no, we're not going to buy into the different vendors. They're way too expensive. We're going to develop our own, and then find out that the information and the data that they've collected doesn't transfer anywhere. So you have really some data transferring issues within that. So again, I'll get into more of that in a minute. Adoption requires cultural and behavioral changes for the use and reliance of it. And this goes to the behavioral changes. Yes, being willing to accept change and moving forward and learning how to use the different technologies so you're competent. And then again, low levels of digital, computer, and health literacy in the general population. And it's pointing out elderly in particular. But again, looking at and working with, if telenursing really works to help, then I think that will resolve this issue of this disadvantage. So some of the next issues we're going to be looking at are security issues related to the telenursing. And again, I've mentioned this, and I think you could summarize. I've mentioned, you know, the competencies, the KSAs, there are lack of data standards. There's lack of interoperability of sharing data. There's security, privacy, and trust. And this you'll hear a lot. Patients don't trust what's going to happen to my information. This was another study one of my PhD students did, was looking at this, and she had within the study she was doing, talking to patients about using the digital technology, but there was no face-to-face, there was no Zoom. It was just my. And the questions that came back from those patients was, so what happens to my information? I don't know who I'm talking to. Can I trust these patients? Can I trust the provider? So who's on the other end, and who am I sharing my information with? So I think we've lost the slides, but I'm going to continue. I've got my own paper version here. So if we could get those back up, that would be great. So security, privacy, and trust are barriers to data collection. And other things that issues and barriers are obstructs access to data and research, and then obstructs funding resources. Okay, so the next slide, security and issues, more issues related to telenursing practice it's the next slide, which is slide 19. There, okay. So this is one of the regulatory acts that the Congress, our federal government, is putting in place. It's called the PATCH Act. And this is an act that has set new requirements for medical devices and network security, including the cyber attacks that you may be seeing and experiencing. And so the PATCH Act would impose cyber security requirements. In other words, if you're developing a system, you absolutely have to have an address and be certified that you do have cybersecurity requirements applying before you get the approval, the vendors, before they get approval from the FDA. Enables manufacturers to design, develop, and maintain processes and procedures to update devices, but then they have to continually be sending in reports that they have done this. They have to establish a software bill of materials that the device providers are using. This goes to standards where not every different healthcare organization is doing their own thing. There needs to be ability to transfer data across multiple providers and technology. So this also provides for requiring development plans to monitor, identify, and address the cybersecurity issues, and certainly provides for a request for coordinated disclosures that they can report. So the next slide is looking at interface and usability. HCI, if it's called, as it's called in the certification exam. And this was an example of a study that was done using a tool called the Telemedicine Usability Questionnaire, the TUQ. Excuse me, can't say that. TUQ. And this was done at George Washington University, looking at their particular patient population of cancer patients. And this was during the pandemic. And they sent out this questionnaire after the patients had used their computer system, you know, the virtual, the digital, the face-to-face, you know, sending their vital signs, monitoring back and forth. And so they sent this questionnaire out to the patients after they had been able to use their system for a while. And it was interesting, it came back that 49% of the patients were very satisfied with the system. 34% said that the usability was, they were able to use it, but then still needed some other help with other more advanced technology. There was an acceptance rate of 11.5%. That's pretty low for this group. I think it's, if it were done again, you would see a higher percentage there. And then implementation of the services was 2%. And so again, this goes to trust. Were they able to use it competently? And then to give you a little background on what this questionnaire evaluates is looking at all usability factors, such as how useful was our system? How easy was it to use? How effective was it? And is it reliable? And then the patient satisfaction, which again was the highest score. So with that then, and this was evaluated on a 7-point Likert scale. So then looking at the next area are exemplars in practice. And I wanted to give you some examples of how telenursing is being used. And this was, again, the George Washington, they did a second cancer center, they did a second usability question study and found that patients scored it at a 5 out of 5 for interaction quality and ease of use, 4 out of 5 for usefulness, 3 out of 5 for reliability. And this was 70% of the patients agreed strongly that the telemedicine made them feel safer. I thought that was an interesting finding. And then 63% agreed that it reduced stress, you know, the stress of having to get ready and travel and waiting and those type of things. I thought too, one of the most interesting findings was that within this very practice university setting, that the providers, 88% of the surveys were completed. Most of the providers, the younger providers, if you'll notice this, 30 to 39 was 37%. The older ones were 23% that responded. And then 47% of these said the experiences with telemedicine were very satisfactory. So that was a really, I thought, interesting study, and one that should be repeated again to see now, since we're further into COVID and, you know, the pandemic, the year 2 and 2.5, and moving in, the telehealth now and telenursing is becoming more the norm. So I think it would be interesting to repeat these studies again. So looking at the next slide is looking at the telenursing EHR interoperability, the electronic health record interoperability and integration. So defining interoperability, and I think you probably all have a sense of what this is the secure sharing of health data across the healthcare systems. and making sure they can speak to one another. And this is an issue and a barrier I brought up earlier, is where all of these different healthcare organizations across the country were trying to develop their own unique system because they didn't want to be paying a vendor. For example, Epic. Epic is the one I'm most certified in. There's Meditech, there McKesson, several others, but they didn't want to be paying the vendors for something that they thought they could do in a more cost-effective way. But then they found out that they couldn't share data across different systems. So that became a real issue. And these are needed to due to the huge amounts of data. You know, now it's, you know, we hear about big data and how are we going to analyze it? How are we going to accumulate it all and then be able to do the analysis looking for trends? So just doing that, and you can imagine if that were still within a paper world, what a nightmare that might be. So again, when you can use interoperability and analyze the data and trend the data, then you can get a better sense of making patient care decisions. And especially during the pandemic, what worked well. And I think you'll remember that getting some of this information quickly and getting it and changing practices across the pandemic very quickly. We've worked and moved forward more quickly than we have in many years in history. Sometimes they were able to get new treatments out within 8 to 10 months versus years and years and years. And I used to be an NIH study coordinator where it typically took 5 to 10 years to get really good results back. And no longer is that acceptable now that we have this technology. So next we're going to be looking at, again, more issues in interoperability and integration. And this report came from our ONC, the Office of our National Coordinator for Health Information Technology. And they define telenursing. Certainly, and I think you're all aware of this, is the electronic health record, which includes the analytic systems, biometric monitoring, and certainly other digital systems. And the ONC has stated that the data must be integrated, automatic, not manual. And clinicians at the point of care, it provides for them to make an improved diagnosis more quickly and treatment. And this is what I was talking about, you know, versus our very long-term NIH clinical trials that take years and years and years. You saw how quickly the vaccines were developed and out. And again, getting data back very quickly so that decisions could be made. Additional information is from the ONC is that users must be able to find and use the information on both ends, whether sending that information or receiving it. And getting back into receiving it, I'll talk more about data blocking, where we have regulatory systems in place to address that. And this includes third-party systems like the IT vendors. You know, are they blocking because of competition? They don't want to share what they're doing and what they've found because it might give the advantage to one of their competitors. So again, the ONC has stepped in and put plans in place to address these, and I'll talk a bit later about fining, what the big fines. And they're saying that there must be automatic access to clinical information when treating a patient. So the next one again is more issues related. This is a big, one of our biggest issues in barriers to practice. And we've talked a lot about lack of interoperability and what it does. It limits the data sharing, data comparison, you know, decision making, that type of thing, because we don't have the data. From the systems perspective, there are too many standalone systems with non-integrated data. And, you know, this is a huge barrier to practice and being able to make competent decisions. There are many different databases and, you know, again, I've mentioned this. With the current lack of clinical standards for automated decision support, there's no agreement in alarm and trending setting services. When I worked as a project director for the EHR implementations that I worked on nationally and internationally, it was many times there would be many arguments where different physicians in decision-making roles would say, oh, we don't want these alarms, you know, for example, if it's a med interaction or an allergy, we don't want alarm for that. If, you know, we get a notice that that med shouldn't be given, they put in overrides potentially, which has caused problems. So it was different from each different organization that they were allowed to make different decisions regarding the different alarm systems. There was no standard. And EHR systems do not currently facilitate data integration and automated analysis, and we're really working on that. So some of the new regulations coming up are addressing this. So in the next slide, we're going to be looking at systems developers, issues, and administrators. And again, time and cost limitations, as I mentioned before, data issues, limited access, and then data flow into practice. And in the different hospitals, it's regulated. And again, looking at security, HIPAA issues, that type of thing. But again, working on that. So the next thing is looking at the related to interoperability and integration with the pandemic. Now the pandemic, this is the good news. The pandemic has really pushed forward improved interoperability, delivery of treatment, certainly, and that's the telenursing, cost effective, because again, you know, think from the patient's perspective of not having to travel. And time effect, I would add time to this too, and certainly improve transmission of patient data. Within the pandemic, really impacted projects, you know, the long-term EHR projects, for example, I was on were 6 months to a year to develop and implement an EHR. Now it's like that, no, you need to get this done in a week, in a month, in 2 months. And you've seen those changes. We've certainly benefited from those changes very quickly with getting, certainly you think the example of the vaccines and other treatments. So long-term costly IT interoperability projects were paused or even, you know, put on the shelf. And some of them may never come back because of all of the changes. Priority patients in remote areas have received care in homes, and certainly the direct messaging capabilities are used to replace fax workflows. Now, how many of you can think about, you know, how many times you've faxed in the last month or 2 months? Faxing is no longer essentially a regarded workflow. So within the next slide is looking at issues related to more issues. And this is a really important slide, and this should have been one of the questions, actually, is looking at the Cures Act. And again, this is one of our federal regulatory acts that has been put in place. It's looking at data blockers. And they have implemented penalties for data blocking for software vendors to be more compliant. Again, not the ability of not sharing data because you think your competitor has that data and are going to do better than you, going out and marketing new things. So the penalties can be up to $1 million. And the requirement is that there needs to be seamless sharing of patient records to reduce errors, and it improves patient outcomes and satisfaction. So inconsistent information across the network certainly is a huge problem, something I've mentioned. So with that, then we're looking at more issues related to the Cures Act and what it's going to do in providing care. So the Cures Act, again, the next slide, is looking at if there's a problem, certainly with inconsistent across the network, and this includes physicians not sharing information across, because there might be competition between urgent care centers from one healthcare organization to another. And this applies also to the providers. If they're not sharing data, they will also be penalized. So there are some solutions that they're considering, certainly identifying a single unified network that interfaces, and this is now required by law. And again, this is essentially a new practice. And again, a solution to trying to hire somebody to sit there and facilitate. You can imagine somebody sitting there and facilitating, you know, going through and reading data and saying, oh, well, this needs to go here and this needs to go here. Facilitating that communication could be certainly very ineffective and very expensive. So what they're looking at is a solution to develop software packages that have this capability. Looking through that and leveraging automation and extension. So then this, again, are some more issues they've come up with and potential solutions. Again, this is with providers not sharing information, patient data across systems or hospital systems. And again, this is what I'd mentioned, competing for patients within the urgent care centers. So it's not whether and when to make the data available, it's a law now that you must make it available, and you must be transparent, make it accessible to the right entities at all times. And this is where the Cures Act, if they find you not adhering to this, penalize. And again, the potential person who is, or the non-compliant people will be fined. And there's even more. They've looked at this. I've seen information even within the last week and month published, you know, on our the HIMSS and the latest healthcare IT websites, looking at the Cures Act and different practices being penalized now for blocking data, you know, within like a physician or physicians partners organization, or different organizations with physicians are really being tracked. Well, it shouldn't be physicians, it's providers in general being tracked. Looking at other issues related to this, certainly this data blocking is a big, really big issue. And looking at EHR certification. If the system that this particular organization is using does not meet the certification requirements, then they will also be fined under the Cures Act. And it's pushing for industry compliance. You know, some of these, you know, you have to go through a certification process when you're implementing an EHR or any kind of a, you know, a patient system, data system. You have to go through a certification process that's reviewed. You have to apply for the certification and then keep it updated. So if it's not, you will also be fined. So there needs to be consistently export and store data in a single place with an online portal that allows access in a central place, not just putting it in a certain place where only certain providers with a certain password have access to that data. It has to be available in a central place online, so all providers, anyone needing that information can access it. And this goes to patient portals. And Epic has a patient portal where patients can go in and see their actual test results and lab results, any kind of information like that, they can access it. And I know one instant where another nurse peer had access to test results before the physician did. And the physician was a little upset with her. He said, "How did you get that information?" She had access through this patient portal and had it. And being an advanced nurse practitioner, really understood pretty much understood what her results meant. So looking at telenursing legal and ethical issues, the next slide, looking at certainly, and I think everyone might be aware of this, the informed consent. Anytime any patient goes anywhere to a healthcare organization, you have to sign or review an updated informed consent. Looking at patient autonomy and legal and ethical issues around autonomy, patient privacy. I think everybody understands that. And that comes, that scenario that I suggested with a patient, that one of my students doing a PhD study, looking at, the patient trying to get information from their practitioner, and it wasn't a Zoom call, it wasn't a face-to-face, it was just like a telephone call. And the patient said, "I don't know who I'm giving this information to and why I should be talking to that person," because there wasn't enough information given to the patient. They felt confident. So patient privacy is a big issue, certainly confidentiality, those all tie together, and data protection and security. These are essentially the 4 biggest issues related to patients and, patients' personal information. Then there's the malpractice and professional liability and integrity, sharing data back and forth or not sharing data. Equity of access is an issue. And then certainly looking at the patient relationship, and that goes to empathy, that brought up, especially with the virtual face-to-face, and then the principle of benefits are being disposed to act benefits to others. And that's something that isn't brought up as much, but maybe something that should really be considered. So looking more at the legal and regulatory, our Centers for Medicare and Medicaid Services, the CMS, has increased reimbursement for telehealth visits. That used to be a big barrier before the pandemic, and why there was so lack of use of the telehealth visits and telenursing. It was like 20 to 30%. And then with the advent of COVID and the pandemic and all kinds of access to patient care shut down immediately, jumped up to 70%. If you go back and look at some of the different data points, you'll see this. It was amazing. So, and again, that barrier was reimbursement, which is really improved. And now with the pandemic varying so much, different organizations are going back and forth and requiring and requesting, please, continue the reimbursement and doing more studies, data collection, and sending this data to the CMS saying, yeah, our patients are really using this. We really need it. Please do not defund this. So there, if you look at, this was 2021 data, and there's even better data more recently. They've announced the waiver allowing more healthcare providers to provide the telehealth and other services, and even across state lines, they were addressing the licensing issues. So again, in some remote areas, the practicing is across state lines is still a little bit of an issue, but our recent research shows that they're really working on that. So next, looking at safety and security, connected health has increased safety and security. Looking at the concerns, certainly there's a lack of quality and evidence-based research. We're looking at the research. We're analyzing within the big data realm and data rivers and integration and analysis is really a big deal. We're seeing more and more universities really working to make sure, especially, for example, nurses in informatics, in like Texas Tech, another area where I teach, has implemented and mandated that the nurses in informatics need to be taking the data analysis, looking at big data, and have those skills, and that's for master's degree. So again, there's a lot being done around addressing all of these different issues. Some of the connected health issues are transferring data. Again, the point of collection, such as the devices, if you're using an iPad, again, sharing that information back, where does it go? And again, it's a security and privacy concern. Again, looking at standards, and we're working on this. Another emerging trend in health research in general is the increased patient engagement. Treating a patient as a stakeholder in the research. And now you're seeing, and you even see some research articles on the patient will see you now, referring to, the patient controlling the visit and the access to care. And I thought it was an interesting topic that the patient will see you now, not the doctor will see you now, or the provider will see you now. So I thought that was a very interesting aspect for that. So we're getting down to the end, looking at other exemplars in practice. This is one, and a very common one that we hear about so many times a day. And this example is John calls his provider and he says he can't make it for an appointment because he's not feeling well. So, think about how telenursing comes in here. This initiates that telenursing return call. She starts to do an assessment. Do you have a fever? What symptoms do you have? And he says, yes, I really don't feel well. And then lists all these different symptoms. So since there's been an increase in the COVID cases in this last week in his area, the nurse encourages him to get tested for COVID. And this can be done. It's not you stay at home for 10 days and then see what happens. The nurse tells him to wear a mask and go get tested. And we do have that capability here, is go get tested. And, if you have, some of the tests now are coming back very quickly. And if they come back positive, then you need to start treatment immediately. And we have that capability to be treated within 24 hours of symptoms, just like you used to be able to do with flu. When you first had the symptoms of flu, you went in, were tested, and immediately started on a treatment. But then, he had to stay home and distance himself from the family and, maintain the COVID access. This is another exemplar practice, and it shows the multidisciplinary team. And this would be, similar to the video conferencing and the remote monitoring, where you get many aspects of the whole team involved. You get PT, you get lab, you get the practitioners and providers. And here they were doing a telemonitoring, vital signs. And again, from a computer in their office, they did some medication tracking, what meds are you on, updating that. They looked at some education. Do you understand, that this is something that you can do to take care of this. So it was looking, in this particular patient, it was looking at arterial hypertension. Do you understand, being careful to not eat any salty foods, those type of things. And so providing that education, looking at the different risks for the different that might cause hypertension, what you can do, the 5 steps to really address this. And then certainly that video consultation, going back and the telenurse, providing the education. So then looking at that and then in 2 or 3 days, setting up another appointment and monitoring vital signs again. What happened to your blood pressure? Did you implement this? Did you cut back on the salt? That type of thing. And then redo the vital sign assessment. And then this reduces the frequency. Certainly this patient didn't have to go back to the office, 2 and 3 times a week to be monitored because they had, hypertension. They had a blood pressure way out of control. And they looked at the medications. And so had maybe started a higher dose of a blood pressure medication like losartan or amlodipine or something, lodipine or something like that, and improved it. So go back and remonitor. And so these visits could be more frequent and lower cost, certainly. So another exemplar was Julie. Was seeing her nurse via the telenursing. She was recovering from COVID, and she's using a secure platform from COVID because the COVID interactive remote monitoring program provides HIPAA compliant platforms for patients to interact with their providers. So she wants to travel to a friend's house now, but wants a different platform, such as the FaceTime, to continue her visits with the nurse instead of using the equipment that was provided, the HIPAA compliant information and platform. So during this time, she can, she was told that other HIPAA compliant platforms include video chat, Google Handouts, video, Apple FaceTime, or Skype, but she still needs to use that HIPAA compliant to continue the main monitoring of the data that she's sending to her nurse. So looking at what is allowed during COVID-19, and again, there are HIPAA compliant, and this I would suggest that you always check because it can change. There is HIPAA compliant, and under this, healthcare providers can use popular applications to deliver the telehealth messaging as long as they're not public facing. And there are many examples of the non-public facing applications. So I hope those are included on the next slide. And these are the secure platforms that are HIPAA compliant. Video chat are the Apple FaceTime, Facebook Messenger, Google Hangouts, and Zoom, and Skype. The text-based applications where they can send vital signs back and forth are Signal, Jabber, Facebook Manager, again, Google Hangouts, WhatsApp, and iMessaging. So this was something that was new information for a number of colleagues and peers that they didn't realize that it had to be HIPAA compliant. So with that, we go into the self-assessment quiz. This was one of the questions on the pre-test. So if we want to go into this, and I'm not sure, what you would like to do, or Risa, what you want to do with these self-assessment questions. You want to go just ahead and let people write down their answers, and then we'll get back to this, or what's your process here? Because I have 5 telehealth self-assessment questions here for this quiz. think that was answer number 1. Number 2. Number 1. This is good.
Professor, do you have my voice?
Yes.
We had planned to launch the posters after you finish and after we on the Q&A.
Okay. Can you say that again?
You're running posters, right? Or is this something else? We were supposed to launch the posters after you finish completely and after people participant asked a question and you answered them.
Okay. So I am done. This was to be a self-assessment quiz. Do you want me to provide the answers for this? I was going to give people a chance to go through it and then maybe provide the answers. How do you want to do this?
Thank you so much, Professor Sipes, for your very nice lecture. I think this is the question answer time. And some
Professor, I'm sorry for interrupting. I'm so sorry. Professor, did you just finish completely?
I have finished everything except, you know, giving people a chance to respond to the questions. I am done with the lecture.
Okay, I think you can continue this part, then we can have question answer time.
All right, then.
Then I ask Mrs. Smiley, please open the slide to finish the last part of lecture. Thank you. Thank you. So, dear Professor Sipes, you can continue. Then we will have, after finishing, we will have question answer questions of participants. Thank you so much.
All right.
I see people are still responding to the self-assessment quiz. This is great. Number 1 was false. The key was face-to-face office visits where patients use a computer. It's not face-to-face, it's virtual. Number 2 is all. Number 3, barriers to telenursing is computer literacy, resistance. I listed several there. Oh, good, good. The answers coming through are really good. Okay. Number 3. Number 4. There were 14 core competencies. That's, I believe that was slide 15, you know, is helping nurses, helping patients, time saving, care planning, emergency, yes, cost effective, enhancing communication with patients, the care planning, also the technology skills such as ability to transfer data, assess data. I see answers still coming in. That's good. That's good. Advantages to telenursing. Yes. Perfect. Cost saving, access, no travel, those types of things. Most acceptable by students. Very good responses. Reduces travel time. Yes, definitely. Cost, yes. These answers are good. I really like to see this, yes. Okay, I have a question for participants now. Is there a big difference in what I've shared we're doing in the US with regarding telenursing and telehealth in general versus other areas of the world for other attendees? Is there a big difference, or are you doing some similar things? Cultural gap, yes. Oh, I want to hear some of these comments. There was a response before this social distancing. Let's see this one. How can we apply it to aspects of nursing? I didn't see the full question. Oh, this is interesting. The question was, how can we apply it to aspects of nursing that require physical touch, like wound dressing? And that was something I pointed out earlier. Sometimes with minimal wounds and minimal wound dressing, it would be, you can teach them how to take care of themselves, use an example like a simulation or that type of thing with a model and show them how to do the dressing. But if it's, extensive, that's where telenursing probably won't work. There are some examples where telenursing really wouldn't work, because you think about when you're doing a wound dressing change, you need to not only change the dressing, but you also need to evaluate and assess, for any kind of infection, that type of thing. Is it actually healing, or is it, are there other issues going on with that wound? So in that case, you would actually need that visit, the hands-on. Any other questions like that?
Yes, there was another question. Mr. Nematullahi, are you here?
Before we go into the card, I want to say that I was so impressed by Professor Sipes' lecture. It was really nice. Thank you so much. And till now, we got 3 questions, 2 of them on mine, since I was liking it. The first question of mine is that in United States, is this telenursing being utilized actually or not?
Absolutely, yes. And especially in our major
Good.
areas, population areas, and they're trying to get it more in the remote areas, like I said, Montana, Wyoming, where patients have to travel further. Some cases, what they've done is if there's an injury or something like that, they actually, since they don't have the telehealth nursing yet, they have some to some extent. But what they've done is they fly in flight nurses to go actually,
that's great.
yeah, in those really remote areas where a patient's 500 miles.
Mhm. So we have another question from one of our participants, and it asked if there is any specific education or certificate that nurses need or enroll to become an actual telenurse.
Actually, that varies with different areas of our country of where they're doing that. For example, the East Coast and more in like the New York area, the more intense areas like that, the practice and the curriculum is more advanced. And here I'm in Denver, I'm in the West, like in the, not Midwest, but West, Denver, Colorado. And we do have very advanced practice here. The nurse practitioners do this, and it's in the mountain areas. Like I'm in Denver, Colorado Springs is more mountain area. Pueblo's even more. It's more kind of South Colorado, where it's more desert and migrant workers, that type of thing. We have areas that are called critical care access, and they're federally funded. They get extra funding, and they have all of these different programs, the curriculum. And my daughter actually is a nurse practitioner with her DNP, Doctor of Nursing Practice, that worked in a critical care area. And she actually had more advantages than the nurses in Denver, because here there are so many that want to practice in the big universities and the big hospitals that it's very limited access. But where she was, they were so desperate for any kind of health care that she had these opportunities to do so much more. And, taking care of patients with comorbidities, cardiac, diabetes, asthma, all kinds of things. So she had more advantages there for actual practice. And she worked in conjunction with physicians. She would also travel to another area, a couple hours area like Pueblo, more along our main corridor, and be able to get updates and practice and take the courses. And then she also took a lot online. She had that availability, but she had to do some clinical practice too. Does that answer your question?
Yeah, of course. And another question relating to my previous question is that how many hours a nurse, simple nurse, should be practicing to become a telenurse? How many hours do they got?
It depends. For like it's tied in to integrated into some of the FNP programs, the Family Nurse Practitioners programs, and it might be like clinical practice hours, 140 hours, where they have to do
140 hours.
140 hours. Well, and that's clinical practice.
So normally it will take a couple of months to get it completed, right? Or
Yes. Yes.
That's awesome. That's awesome. And again, thank you for your lecture and the time you gave us. I'm so glad that I met you and knew you. Actually, I'm a student, and I'm so glad that I can, through these program, meet great people.
I wonder if there's any way the US can share programs. And Dr. Hebda, do you know, is Dr. Hebda still here?
Dr. Hebda is still here, and I know that with Ramadan, people are concerned with time. So I'm thinking we may need to continue this discussion. I would love to see some international collaborations. I don't know what we would need to do that. Maybe some of the schools already have some issues that they've started.
So,
Thank you, Professor Hebda. It's our honor to collaborate with you.
It was an honor.
in the program. Thank you so much. We will continue discussion about this session next week, I think, if you
Okay.
agree.
Great.
Because
Thank
we
you,
have-
everyone. I really enjoyed doing this. Thank you, everyone.
Thank you so much, dear Professor
too.
Sipes. Thank you.
It's me.
And I think now is the time of poll, post-test.
Yeah.
Would you please
We
launch it?
have a poster, so dear participants, please participate in this posters, and then we can finish the session.
And before that, we will take a group photo before the end of session, after poll.
Yeah, we're gonna have a group photo for, and yeah. Everyone, please participate in poll. Do it. It doesn't take much time.
This is 20% participated.
Yes.
19 out of 82. We want more.
Yes.
While people are thinking about this, maybe I could mention, those who said you didn't have the programs, you think about how we could share a program. And I think we've done that with some other, at Walden University, we've done that with some other universities or organizations like in Africa. I know we've done that where one of our faculty would go and support and help bring the program up, and then the students would work internationally with us. So I think we've done that. Again, we are, an international university.
Yes, thank you. Thank you so much.
Professor Sipes,
Yes.
I just missed your voice for a second. Can you please repeat what you just said?
Okay. Can you hear me now?
Yes, clearly. Yes.
Okay. What I was asking was, I saw some of the responses back earlier that they did not have this kind of information, curriculum available for nurses in different areas. And we could collaborate to share our information. And we have done that with another country. I forget, it's an island off of Africa somewhere, where we did share that internationally, where one of our faculty would go there to help get the program set up. And then our students, their students there took the courses internationally, because we are international. We have a number of students. I have a student now from Belize. We've had a number from Africa, Nigeria, taking our different courses. So it is possible.
Yes.
That would be great. Yeah. So how many participants did do the poll?
64%.
I think it's enough.
65.
It would
Yes,
be enough.
it's enough. 65%. You can close the poll, and 67%.
Yeah.
It's okay. Thank you.
So please close the poll, and participants, please do not leave because we're gonna have a group photo.
Yes.
Oh,
Open your
let's see.
camera, please.
Everyone, please turn on your cameras. Everyone. Who's gonna take the photo? Dr. Darvish.
No, this is our appraise to raise team, and it is directed, the photo is directed by Mrs. Sadeghi. Thank you, Mrs. Sadeghi.
Mrs. Sadeghi will do it, right?
Yes, yes.
All right.
Good.
Mrs. Sadeghi, did you take photos?
Wait some moment.
Please notify us if you have taken photos. We can close the session. Thank you, Mrs. Sadeghi.
Yeah,
And thank you.
because I keep my eyes open and it they start to burn because
Okay.
I want the photo being a nice photo. Are we done?
Yes, yes. Thank you.
Okay.
Awesome.
Okay, thank you. So you can close the session.
Great.
Mr. Nematullahi,
What? Yes.
you can just notify the audiences for next Saturday. And bye-bye.
Next Saturday, on the exact time, we began 18, right? 18 in Tehran time, right? So
Yes.
next week on Saturday at 18 p.m. in Tehran time, we got another session, and we really want to have you all in that one too. Take care of good yourself, and
Okay.
goodbye.
Bye.
And wish you